Good morning, I'm Dr. Ara Duke-Majan, CEO and founder of Duke Spine Institute, and today is September 19th, 2019, so 9/1919. And we're here at the Duke Spine Institute broadcasting live surgery. This is spine surgery being performed today on 3 patients. The first patient is having a cervical Duke laser disc repair. This patient has herniated discs in his neck, and those herniated discs are pinching nerves. And the patient has extreme weakness of his shoulder deltoid, which is your C5 nerve root, and then also weakness of the biceps. He has 3 disc herniations. C4-5, C5-6, C6-7. The worst one is C5-6, then C4-5. His symptoms are all in his left arm. He has left deltoid weakness, left bicep weakness. He's developing atrophy or wasting of the muscle. And we discussed different surgical treatments, including traditional anterior cervical discectomy and fusion versus artificial disc versus endoscopic Duke laser disc repair. Those are really the 3 options going through the front of the neck. And then, of course, there's laminectomy through the back with foraminotomy or foraminotomy alone. So we talked about all of them. And the least invasive surgery, the one the patient wanted, was the Duke laser disc repair through the front. So that's what we're here to do today. We're going to get started. Our patient is already prepped and draped. Luis, nice job on the drape. The pharyngeal muscles, I think, could be a little bit more relaxed. And when I push on his neck, he seems to be flexing. So for those of you watching the surgery live, this is a live broadcast. We don't edit our surgeries. We don't record them, pre-record them, and then edit them or anything. This is live. So this is real surgery, real time, high definition for you to watch, listen, and learn. And obviously, as issues unfold during surgery, like any kind of complications or problems, you're gonna see them all happening. Okay? And we do this because our purpose here for broadcast is to educate the public about what's available, what state-of-the-art surgery is available. Now, for patients like this that had herniated discs with pinched nerves, the only thing that was available for many, many years was fusion, where you had to take the whole disc out to fix a little piece in the back. And endoscopic surgery, transdiscal endoscopic surgery for the cervical spine was developed primarily overseas in South Korea years ago, about 15, 20 years ago. I don't know the exact date, but I learned this technique about 14 years ago, and I've been performing anterior cervical endoscopic surgery for the last about 14 years. We've had 0 complications. The surgery has been peer-reviewed and published in the National Library of Medicine. That means it's in the United States Medical Library. It is not an experimental procedure. It's a known procedure and known result. All right, I need more extension. I need you to push the donut towards his tailbone and get his neck extended a little bit more, okay? And I'd like a little bit more supple spine. Think we can do that? All right, shot. Yeah. Does he have a gag reflex? All right, 2, 3, 4, 5, 6. So 5, 6, I think, is the worst level. Can we scroll the MRI, please? Other way. I think that's good there. Come on back. Stop. 2, 3, 4, 5, 6. Yeah, definitely he has narrowing on the left side at 4, 5, 5, 6, 6, 7. He does have some bone spurs, so we're going to do our best. We can't take all bone spurs out with the laser, but you don't need to. This is more of an acute injury, meaning that it's happened suddenly. So sometimes with the necks we need more extension, we need a lot of relaxation. All the skeletal muscle has to be completely relaxed. And sometimes we just need more extension. Shot. 2, 3, 4, 5, 6. Shot. 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 Give me an AP. It's a quick AP. Luis, you should know this by now. I can't take my hand out.
Yes, sir.
Alright, so we're a little bit off to my side, but not bad. Come on, Jordan. You need to get that shot done. That looks better. Alright, go back to a lateral view. Shot. 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 AP. Gotta move quicker, Jordan. There you go. Help me hit my arm. Pay attention to what you're doing. Shot. All right, back to a lateral. Shot. Shot. Okay, AP. That looks good, right in the midline. Alright, that's good. Back to a lateral. So the two hardest parts of this particular type of surgery is the access, what I'm doing right now. And so far everything looks good. And then the movement from one disc to the next is the next hardest part. And I'm aiming for that opposite foramen. And because the esophagus is in the midline, shot, trachea is in the midline, it's easier to get to from the opposite side. So for the neck, we do the opposite side. Shot. Alright. AP. You can see we're in the disc. Coker. Shot. How's his blood pressure? That's beautiful. Look at that. You can see the dye is going out the foramen on both sides, but worse on the left side. So that's where the herniation is the worst. So there's a big tear in the back of his disc on both sides. But his symptoms are really left-sided. I don't think he has any right-sided symptoms. Back to a lateral, please. And I think he's got some scoliosis as well. So let's try to get a true lateral. You may have to wag a little bit off from where you were before. Shot. Try to wag it a little bit. You can see the tear in the back of the disc. Shot. Other way. Shot. That's better. That's better. I like that. Just stay there. All right. So the needle's in the middle of the disc, and now we're going to put our guide wire and take our needle out. And the guide wire shot is really going to guide our instrument down to the disc. Shot. Blood pressure is good. No, I'm fine with it. I don't see any hematoma. That's always something you have to check for if you're doing this kind of surgery. Anytime you're putting anything in the neck, you always want to make sure you're not invading an artery or a big vein. And there's nothing there. It's supple. So, which is what we expect. But it's always good to verify. You know, you're not doing a blind procedure, but you're working and passing between some very sensitive areas in the neck, and you want to use all the information available to you to make sure that you're not going to injure anything you shouldn't be injuring. All right, so let's get one more picture, move north a little bit. I want to show C2 to verify we're at the proper level. Shot. So we count down from C2. There's C2, 2, 3, 4, 5, 6. Everyone's in agreement? We're at C5, 6. So we're at the middle disc, which is where I like to start when you're doing a 3-level. All right. So the advantage of the surgery that you're watching over the older types of surgery like anterior cervical discectomy and fusion is that we're going to do this surgery without taking the whole disc out. So there's no need to do a fusion. The only reason to do a fusion is when you have to take the old disc out, the whole disc out. And obviously there's now artificial discs that can be used instead of a fusion. That being said, I don't recommend artificial discs at all for patients because they don't work as well as a fusion. So if I had to choose between artificial disc and fusion, I would recommend fusion because the results are more established and better. On the other hand, the laser surgery you're watching now is, I believe, the best of all three. And the reason for that is, number one, look how small the incision is. Everybody take a look. See this, Zach? That's 4 millimeters. So number one, we have small incision, so less tissue trauma. Number two, we're not taking the whole disc out just to get to a little piece in the back that's pinching a nerve. That's really what ACDF, traditional anterior cervical discectomy and fusion is. That's what artificial disc is. You're taking the whole disc out to get to 5%. That's a problem. And that 5% is in the back of the disc. So the only way to get to it is to take the whole disc out. Well, somebody discovered that, hey, why do we have to take the whole disc out when we can just make a little tube and go past the normal disc in the front that's not causing any problems for the patient and get to the back where the nerve is pinched and just zap away the herniation. And that's what we're doing. So I learned this technique overseas from German doctors, Korean doctors, but unfortunately there's nobody else, really not many people in the United States doing this. So it is better for the patient. There's 0 complications to date in 14 years. You can't say that for ACDF or artificial disc. And there's no implants being put in. There's no metal or plastic that's going to go into this patient. Literally, we're going in and zapping away the part of the disc that's causing problems, and I'm going to debride the annulus so that the disc will heal. See, lots of people have herniated discs, but they don't have any problems from it. They have no symptoms in their arms, their neck. They're fine. Most people with herniated discs don't have symptoms, so we leave those alone. My goal is to make this patient asymptomatic as well, and to do it in the least invasive way possible, and that's the Duke laser disc repair. All right, at this point, we got our guide wire in. I'm going to advance the dilator shot. Any questions from the audience so far?
Not yet.
Shot. You want to make sure that your guide wire does not move forward. Shot. Shot. You want to make sure your guide wire does not move backwards. You want to make sure your guide wire basically stays where it's supposed to. Shot. So now we're at the anterior annulus, okay? So I know for most people watching this surgery, they can't really appreciate what I'm doing. But for a surgeon watching me that knows the anatomy of the neck and knows what I'm doing, this is an incredible feat to be able to do this surgery through this tiny incision. And honestly, I can teach anyone to do it. Not anyone, of course, people that are competent. Really? You think I'm going to put it over it and bang it? No. So we're all in agreement. 2, 3, 4, 5, 6. And I'm on the anterior annulus. I want to make sure I'm in near the midline. You can be about 3 millimeters off the midline. Coker. I'm going to move my hands out of the way because I don't want the radiation. When you do a lot of these types of surgeries, as a surgeon, you don't want radiation passing through your hands. You'll get cancer. All right, so it's really good. We're slightly to the patient's right of midline, which is fine. So we're probably just on the medial border of the longus colli muscle. And you can see the spine's a little bit twisted, so we're just off to the side, to my side, the right side, a little bit, which is fine. It's really good. All right, lateral. So at this point, I'm ready to start advancing the dilator down. I can feel the anterior ligament as I push against it. So you actually have to pay attention to the feeling of the instrument. As a surgeon, you have to feel through the instrument. The instrument is an extension of your body. All right, can we stabilize the neck and give me a little bit of inline traction, please? So I'm going to try to do as much as I can in the very beginning as to roll and push through the anterior annulus with the tip of the dilator. Shot, but you want to make sure that your guide wire does not move backwards. So I've been able to successfully get through the anterior annulus shot. And at this point, I'm taking the guide wire out. And I'm going to finish this. And I want to bring the tip, shot. I'm going to bring the tip of this dilator right to the foramen, basically. All right, that's really nice right there. That's perfect. And then I'm going to bring... So for those of you watching, the entire surgery will be done through this little tiny coffee straw. And of course, this is not really a coffee straw, right? This is more of a very watered down milkshake straw. No, but this is, look at this thing. This is literally 4 millimeters across. And to think that, honestly, if every surgeon, spine surgeon in the world knew how to do this surgery, there would be no more anterior cervical discectomy and fusion, except for very rare cases where there are huge bone spurs. And even then, most likely they'd go posterior, through the back, where it would be safer. Like for OPLL, ossification of the posterior longitudinal ligament, where it's more dangerous to go anteriorly, most surgeons will just go posterior. So honestly, I think virtually 100% of ACDFs around the world will end with this particular Duke laser disc repair surgery that I created in the future. And there'll be no need for metal plates, no need for bone graft, no need for fusion, no need for screws and all kinds of devices that we put in that, number one, are harmful, in my opinion, to the patient. They're also completely unnatural. And of course, they're really helping the wrong people, which are the big companies that make them and charge a lot of money for them. So this is really the best surgery in the world for the patient for a herniated disc in their neck. And again, the whole surgery will be done through this tiny little tube, 4 millimeters. And we're going to try to fix all 3 discs with this one incision, which I think we'll be able to do, but we don't know yet. This patient has a pretty muscular neck.
We have a question.
Sure.
We have a viewer asking, what are some of the possible complications for this surgery, and what's your complication rate?
So one of our viewers says, Dr. Duke, all surgeries have complications, right? What is the complication rate for this surgery? And what are the types of complications? So just for those of you who don't know what a complication is that you moving him?
I'm pulling the neck.
Yeah, he's not moving himself, obviously. Yeah. Complications are things that happen as a result of medical treatment or surgical treatment. Things that happen that shouldn't happen, that are not beneficial to the patient. So not beneficial things that happen during treatment that shouldn't happen, that you don't want to happen. And by the way, if some people think complication means equals lawsuit, it doesn't. Complications, every surgery is known to have complications, certain complications that occur. And when you disclose that to your patients, you know, through an informed consent process, which every surgeon should do, let's get an AP real quick, then the patients are aware. And having a complication doesn't mean that you should be sued. It really means that that's par for the course for having complications with surgery. So nobody wants a complication. Patients don't want it, doctors don't want it, hospitals don't want it, insurance companies don't want it. Complications are bad. You don't want them. But they do occur. Now in this surgery, the Duke laser disc repair that you're watching, it is the only surgery really in the world that has had 0 complications. Part of that reason is because there's one surgeon doing it who's really good at doing them and is very careful, is a good surgeon. That's me. The other part of the reason is that it's a very safe surgery to do, as long as you do it right, just like any other surgery, as long as you do it right. And then I'd say another thing that's important is that it's not an emergency surgery, like someone's dying and I gotta go quick, and you know, when you go quick you may make mistakes. So we can take our time, we can do it right. I have lots of experience. This is about 1,000 of these surgeries that I've done, the laser surgery, Duke laser disc repair. But the fact of the matter is, in 13 years that I've been doing this surgery, I've had 0 complications. In 1,000 surgeries, there hasn't been a single intraoperative complication nor a postoperative complication. The only thing I could tell you is that the recurrent herniation rate, which is lateral, which is the chance that the patient will get another herniation right here where we did the surgery, is 1%. So 1 out of 100 patients will have a reherniation at the same level that's been operated on, which is actually very low. It's below the industry standard, so that's very good for the patient. So we don't want reherniations, but the only times I've ever seen recurrent herniations was when patients when they lift too much or they bend too much, they do something they're not supposed to do. So as long as the patient follows instructions, the chance of getting another herniation at the same place is very low. We put all of our patients in a collar, a rigid cervical collar called a rigid cervical orthosis, and they stay in that collar shot for 6 weeks. Shot. All right, so I've advanced the tubular retractor, and it's called a tubular retractor because it's the shape of a tube, and the whole surgery is done through the center of the tube. And it's called a retractor because it retracts tissue to the side. So in surgery, in all surgery, surgeons use retractors where they actually push the tissue aside so they can get to a deeper area of the body and they could get down there and work or see. And so we have a tubular retractor, and that's exactly what we've done. We've pushed the tissue aside. So now that we're inside the disc, we're all the way to the back where the herniation is that's pinching his nerve. We're going to go in with the laser and a scope, and we're going to zap away the herniation. And when we're done, we're not going to take anything out that doesn't need to come out. The only things we're taking out are the herniation. We're leaving the rest of the disc, 95% of the disc that's already there, we're leaving it alone. And that part of the disc we're leaving alone is the part of the disc that still works fine. There's nothing wrong with it. So that's why this surgery is so amazing, is that it only takes the part of the disc that's a problem out, which is the herniation and the annular tear that gets debrided. So really it achieves the same goals as open surgery with a fusion or artificial disc, except it doesn't cause all the collateral damage to the patient, to their neck, to their, all the scar tissue, there is none. Removing all that normal disc that doesn't need to be removed because it's not causing a problem. All that stuff is not happening in this surgery, so it's much better for the patient. Just so you know, some people might say, well, Dr. Duke, you're just saying this because you don't do anterior cervical discectomy and fusion, or you don't do artificial disc surgery. But that's not true. Of course I do. I've been doing neurosurgery for 22 years. I'm board certified. I've done 1,000 anterior cervical discectomy and fusions, just that surgery alone. That's not the most. There are doctors who have done 2,000 by the end of their career, but 1,000 is a lot. 1,000 is a lot. There are probably 80% of neurosurgeons won't do 1,000 ACDFs in their career. And I've done 1,000 ACDFs. All right, let's bring the light intensity down. So I do know what I'm talking about. A little bit more down. We're overexposed. Maybe a little bit more. One more. All right, that's good. Laser on at 20?
Yes,
All right. So I do know about fusion. I do know about artificial discs. I was trained to do both of them, and I've done both of them. But this surgery is much, much, much better than a fusion, an anterior cervical discectomy and fusion. And it's much better than an artificial disc. So the herniation is right down there where the blue stuff is. This is also part of the herniation right here. And our goal here is to get in and basically decompress the nerve root within the foramen. We're basically looking at the back of the disc right now. And see that gold area right there on the left at 10 o'clock? That's the end plate of C5. It's the inferior end plate of C5. This is the superior end plate of C6 on my right at 3 o'clock. And we're looking right in the crack of the disc, right where the herniation is. And that's part of the herniation right there, that blue right there. And I'm zapping it away with the laser. Now the laser's at 12 o'clock, you know, 12 to 1 basically. Let's just say 12 o'clock. It's that glass thing at 12 o'clock, all right? And this is the herniation right there. Amazing. Look at that. There's a piece of it. So we didn't take any of the normal disc out. We didn't have to split open the neck like everyone else does. There won't be any scar tissue after the surgery, basically in the neck, because we're going through a 4mm tunnel. Whereas open surgery, you're going to have lots of scar tissue. Not a single patient that's had this surgery has had trouble swallowing after surgery, whereas 100% of ACDF surgery patients have trouble swallowing. And not a single patient that's had the Duke laser disc repair has ever had a vocal cord damage or a nerve damage to the vocal cord. It's called the recurrent laryngeal nerve. Never, not one. No patient has ever had a sympathetic trunk injury. See this part of the herniation right here. So all the complications that typically happen with anterior cervical fusion, artificial disc, we've had zero in 13 years of doing this surgery. 13 years. There's not a single surgery out there in the world, let alone a spine surgery, that's had zero complications except for the Duke laser disc repair. And again, part of that's because one surgeon who knows what he's doing is doing the surgery. That's me. All right? And unfortunately, I'll be honest with you, not all surgeons are created equal, okay? I'm sure you probably know that, right? Just like not all boat captains are equal, not all jet fighters are equal. There's just inequality in everything in life. And in my opinion, there's a lot of sloppy spine surgeons out there. I'm sorry to say, but there's lots of ways to do spine surgery. And I've seen so much bad spine surgery. It's incredible. Not my spine surgeries, but other doctors. So what I'm seeing are the fibers of the posterior longitudinal ligament right there. And I know the herniation is gone from that part because I can see the fibers of the PLL, and I don't see a defect in the PLL. So this is going to be the foramen over here at 5/6. And we're going to go explore the foramen and get all the herniated fragments out. I'm also going to go to the midline, and I'm going to check and see if there's herniation in the middle. Remember, when we did the discogram, come on, Luis, all these cords should be perfect, right? I mean, not tangling on each other and everything. When we did the discogram, remember we saw a big tear that in the back of the disc that leaked out. And where it leaked out is right here, what you're seeing right here, this space that I'm in. It's between the back of the disc and the posterior longitudinal ligament. That's where the dye went. There's a piece of herniation right there. A little bit calcified, but mostly soft. So this patient that we're operating on has horrible neck pain, can't turn his head, it hurts to turn. He has weakness in the arm, and that weakness is really why he's having the surgery. The weakness is bad. The weakness started recently, and he's very concerned about the weakness. So am I. Weakness, when somebody has weakness from a pinched nerve, there's no waiting on surgery. It has to be done. Okay, waiting, maybe it's going to get better. No, wrong decision. And honestly, there's all the herniation right there. Honestly, surgeons need to make sure they explain that to patients. Doctors need to explain that to patients. There's a herniation right there. It's called a reverse. It wants to come back. It's going to come back towards us. But that little piece is hitting on the nerve right there. See that little wiggling thing? I'm zapping on it right now. It's jiggling around. It's jiggling around because it wants to come back into the disc where it originally was. Get out of the foramen and back into the disc. So we've coined the term reverse herniation with the Duke laser disc repair. What it means is that when a piece of the jelly in the center of the disc spits out backwards and hits a nerve through a tear in the annulus, when we start doing the laser surgery and that piece comes back into the disc, we call that a reverse herniation. And the Duke laser disc repair is the only surgery in the world that's ever described a reverse herniation, because that's the only surgery that can have a reverse herniation. And that has to do with the way we do the surgery, that nobody else does it this way. So this is where the nerve is. It's just underneath here. We don't want to see the nerve, and there's a piece of herniation. I'm going to try to get out right there. It's sitting just underneath the nerve. Come on now. Get out of there. One thing about the laser is that everyone thinks a laser just burns. It doesn't. It also makes things dance. So we have our dancing fusion patients, and we have our dancing laser herniations. Oh yeah, nice. See all that material in there? Pretty cool, huh? Sitting just underneath the nerve root.
We have a couple questions.
Sure.
We have a viewer asking, what is your view on spinal nerve root injections and how long do they last?
What is my view on nerve root injections of the spine and how long do they last? First of all, nerve root injections don't do anything to fix your problem. They just temporarily cover something up. I don't recommend them. I don't usually use them. I think they're an unnecessary test. I think they're unnecessary treatment that doesn't work. So I guess that's my opinion on them. I don't like being so dogmatic about things, because if I was so dogmatic about things, I would never have learned laser surgery. But the truth of the matter is there's certain things that are done in spine that should never be done. I'm not saying a selective nerve root block shouldn't be done ever, but a myelogram should never be done. That was an old technique, and it should never be done. Now, selective nerve root blocks, in my opinion, are just there, right there with myelograms. You know what I mean? It's like I would never order a selective nerve root block. We don't do them at Duke Spine. And we have the ability to do them, we don't do them. We don't do them because it's just I don't believe in doing things to people that don't work. I think, the things that we do at Duke Spine Institute, we know have a good chance of working. And that's why we do them. We don't always jump to surgery. A lot of times we recommend shots first. Pretty much as long as there's no weakness, we're going to recommend, if there's pain, we're going to recommend shots first. But selective nerve root blocks are just a waste. Why do people do them? Because they make money doing them. That's why. They don't help the patient, they help the doctor. And I don't believe in doing things that help the doctor, but not the patient.
June, this suction is working?
Hey, what's going on? All right, leave it alone. It's fine. You just don't want my feet getting wet. Sue, you hear that? Genuine concern for my shoes and my feet. I like my feet to stay nice and dry and warm. All right, so I'm on the opposite side. You can see there's still herniation on the other side. Not as bad. I don't feel good about leaving any herniation. And it's easy to get to the other side of the disc with this technique. So I feel like I've gotten most of the herniation out of the foramen on the patient's symptomatic side. I'm going to try to get a little bit more. If there's any more, I want all of it out. As much as I can get out safely. These are all pieces of herniation that we've released. Most doctors don't understand what that means, to release a herniation. That's because they've never done endoscopic surgery. But here's what it means for those of you that are interested. When you get a herniation of a disc or a disc bulges are herniations, by the way, they're just small herniations. When you get a herniation, what's happening is your annulus fibrosus is tearing, and it's allowing the jelly contained within the annulus to leak out. And that jelly is really a pressure, like a pad, and it's really ingenious design. But basically the jelly is like a pressure pad in the middle of between your bones, okay? And that jelly or the nucleus squeezes out through the annular tear. Well, what it does is it creates inflammation because the outer annulus is innervated and it has a blood supply. And so whenever you get nucleus pulposus next to a blood supply, you're going to end up with inflammation because the nucleus pulposus is very inflammatory, right? We all know that. That's been established. The nucleus pulposus is highly inflammatory. So if you put it in the outer annulus, which is what's happening, all right, if you put that nucleus pulposus against the outer annulus where there's a blood supply, because the inner annulus has no blood supply, and it normally lives with the inner annulus. But now it's squeezing out through a tear, and that is causing, inflammation. Well, it's the inflammation then that scars that fragment down to the annulus, and it won't go anywhere. It won't come out on its own. It's really hard to get out. You actually have to release it, and you release it with a laser, just like I'm doing right now. I'm trying to get that herniated fragment out. You see me working on it, right? And I can't get it out because it's scarred down. Here's another fragment right here underneath the nerve root. And I'm trying to get it out, but it doesn't want to come out, so I'm just going to burn it down. And burning it down does the same thing. It basically, burning it with a laser is what I mean. And it basically shrivels it up, shrinks it up, and gets the pressure off the nerve. In this particular patient, we really are dealing with a compressed nerve in the foramen. And we're in the foramen right now. We're quite literally just peeling herniation off the nerve on the left side. So there's no other surgery in the world that allows you to do this but endoscopic surgery. Yes.
We have a viewer who's asking, I'm from the UK. There's a clinic here that offers a surgery called Percutaneous laser disc decompression.
Yeah.
How does that differ from your surgery?
Oh, it's a great question. So a percutaneous laser disc decompression is done usually by pain management doctors, and it's where they basically stick a needle in the disc like I did in the very beginning, but instead of then making an incision and bringing a retractor and an endoscope, they don't do any of this. They just stick a needle in, and then they put a laser fiber like this one down there, and they hit the pedal and zap a few times, and whatever they get, they zap, but they're not seeing anything. They're just blindly zapping a laser into the disc. And honestly, it's a worthless procedure. And percutaneous means it's done through the skin, like with a needle. We're not doing a percutaneous procedure. We're doing an endoscopic procedure. So there's a very big difference between percutaneous and endoscopic. Percutaneous procedures don't make incisions. Endoscopic surgeries do. So endoscopic surgery is a real surgery. Percutaneous are needle-based procedures. Okay? So with that percutaneous laser decompression, they don't actually see the herniations like we are right now. You guys can see these herniations. They don't actually take them out. They just hit the disc with some energy and that's it. They're done. It's, I hate to say it, very minimal skill required, and it's not even considered really a surgery. This is a real surgery. I'm actually targeting the herniations with the laser here. And we're removing chunks of herniation. I'm going to try to get out in that frame in a little bit more. See what else we can get out of there. Sometimes once I get a little bit of that first herniation out and get some of the scar tissue loosened up, I can actually mobilize the disc a little bit better, and I can get some of these fragments to just wiggle out. But I'm literally right on the nerve root right now, just above it. Just superficial, we call anterior to it. And that's a herniation fragment right there. I'm trying to whittle down. Let's get some of these pieces out. I feel pretty good about this so far. I'm going to go peek across the midline.
We have another question. We have a viewer asking, if a compressed nerve is not treated, can it lead to Cauda Equina syndrome?
If a compressed nerve is not treated, can it lead to Cauda Equina syndrome? The answer is yes, for sure, but not in the neck. In the neck, it's you don't have Cauda Equina. Cauda Equina are the nerve roots that come off the end of the spinal cord. That always happens in the lower back. Okay? There's an area called the conus medullaris, which is the end of the spinal cord, and that's usually at L1, L2, and that's your lower back. And then after the spinal cord ends, you got nerves running down, and it looks like a horse's tail. If you've ever seen a horse's tail, for those of you who know what I'm talking about, that's why they call it Cauda Equina. Equina is horse. Cauda is the tail of the horse. So, 200 years ago, 300 years ago, when they were doing anatomy on cadavers and stuff, they would notice that all the nerves down there, they look like the horse's tail. So they used Latin to describe, to name what they were seeing. That makes sense? All right. We're done with the patient's right side, which he didn't have much symptoms.
Right side, please.
Well, no. I'm going back to the left foramen one more time, because sometimes a herniation will slide out from the foramen or from under the tube. You can see the foramen is totally decompressed. There's just a little bit more here. I'm hoping that I can get some of these fragments to jiggle out rather than have to use the laser to burn them out. because using a laser is always going to be more risky than using a pulse wave. All right, let me see what we got in here. There's just these herniations just got kind of scarred in from all the inflammation they were creating. But I feel like we got a really good decompression at this point. There's always going to be some bone spur that I can't get that's not necessary to get. So if you're looking at your MRI afterwards and say, oh, there's still some bone spur, of course. There's no reason to take everything out. If it's not bothering the patient, you leave it alone. You're never going to make the disc go back to normal, ever, no matter what you do. You're never going to have a perfectly normal disc again. I think I can get a little bit more of this material. That'll help them. So every piece of disc herniation I get rid of, I do it because I think it's going to help the patient. I don't just take the disc and remove it because it's there. I do it because it's going to help the patient. And every surgeon should always be thinking, is what I'm doing right this second helping? Because if it's not, there's no reason to do it. Seems kind of obvious to say that, right? But you'd be surprised how many surgeons do things because they have no clue what's really going on. All right. I think we've gotten 90% of the herniation out of this foramen. And I'm just seeing PLL, 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 which is posterior longitudinal ligament. And I think that looks really good. Here's PLL in the middle. I don't think we need to take anything more here. Everything is decompressed. There may be a little tear right here. I'd like to see it. But on the MRI, it doesn't look impressive, like there's nothing major going on in the middle. Now you see how we were able to remove the herniation from right there in the foramen? We were able to remove it without fusing, without taking the whole disc out. Okay, we're done at this level.
Lights on, please.
So, every other surgeon in the world is going to have to take the whole disc out. Only the ones that can do this type of endoscopic surgery can actually leave the disc there. You don't want your disc taken out. You want it there. The problem is, no one else knows how to do this. Very few surgeons in the world know how to do this kind of surgery. It's not easy to do. It takes very specific type of training, very high level training, and the right equipment, which most hospitals don't even have. Like, I don't know very many hospitals at all that have this equipment. Okay, is that water that cold? Because my finger is like numb. It's cold, right? That's amazing. I can't even feel my fingertips. I've never had my fingertips like, I think I have frostbite. I mean, it's good that it's cold.
Yeah.
Did we do something different?
No, just
All right. Different refrigerator. Really? Shot. So now I'm going to take the tube out and I'm going to leave the dilator in, right? You can see it out there in the foramen. I'm going to take the working channel, the working tube out. Okay? And I'm checking. I don't see any hematoma. It's beautiful. The neck is supple. I do like to apply a little pressure just in case. Shot. All right, so what I have to do next is I've got to move this. I've got to move this to the next disc. And I either have to go above or below. And I want to make sure the neck is very supple so I don't have much resistance. This is all done with feel and x-ray pictures. You can't actually see with your eyes because you can't see down there. So you have to actually have a feel, and you need the neck to be supple. We've literally lost a drop of blood so far in this whole surgery. 1 drop. That's, you know, you need 20 drops to make a mil, right? So we've lost less than 1 milliliter of blood. We've lost literally 5% of a milliliter. It's nothing, absolutely nothing. That's one of the other things about the surgery that's amazing, is basically bloodless surgery. All right, are you ready? So I'm thinking that we go for 4-5. I don't know, 4-5 is talking to me. 2, 3, 4, 5. 4-5 I think is worse than 6-7. So I want to go for the ones that are the worst. You never know if you're ever going to have to abort surgery shot. So you always want to make sure you, as a surgeon, you pick, I believe you have to pick the worst levels, you know, the worst areas first. Because if something happens later in the surgery and you got to stop, at least you want a good result. You know, if you can't finish the surgery, you want the best result that you could possibly get. So you got to go with the worst levels first. All right, I'm going to need to see where we are with a Coker AP. So I'm a big believer, like if you ever have to abort, you want to have done the most important things first, so to give the patient the most benefit. That's a philosophical thing. All right, I could probably, why are we so overexposed and over-rotated? Let's go. I need a shot. Taking too long. Get those spinous processes in the midline. And you're overexposed. You're rotating the wrong way. Shot. Is this neck straight up and down? All right, that's pretty good right there. So I'm pretty close to being, go lateral, please. Shot. Shot. Are you holding his neck? Shot. Shot. Give me an AP. So as you do this, you want to make sure you're not going off to the side. I mean, you can go a few millimeters each side from midline, but watch your hand. Come on, Luis, this is not the time to mess with that. That looks pretty good. I like that. Back to a lateral. So I'm pretty close to the next disc. I want to move it north about 4 millimeters. And then I'm going to verify that I'm still in the midline, because you want to go into the disc in the front and the midline, as close to the midline as you can. That's safe. You don't want to be messing around too much moving things. But shot, if you, the thing about being a surgeon is you really have to be decisive. Shot, if you're not decisive, you can't be a surgeon. Surgeons are not indecisive people. Shot. The more indecisive you are, the less likely you ever be a good surgeon. You have to know what to look for quickly and make a decision and go. If you sit around waiting, things change. And then you're reassessing and reassessing, and there's change and reassessing and change and reassessing, and in the end you get nothing done. Shot. It's kind of like those crocodiles in Africa. Can you get the spinous processes lined up, please? It's kind of important that you do that. Shot. God, Jordan, you're killing me, man. Shot. Other way. Shot. That's a little better. It's a little better. Shot. It's fine. Shot. All right, let's go lateral. Let's move it. All right. Mallet. Shot. That's great. Shot. All right. Give me an AP. So all that moving around is, we've lost probably now about, huh? Hold on. Let me get this coker in here. Probably about a milliliter, which is still really good. That looks good. Thank you. Let's go back to a lateral. Mallet. So I want to advance a little more, and then I'm going to pipe clean so we can do a discogram. A discogram is an important part of the surgery. Shot. Perfect. So discogram is where I inject dye that allows me to see the herniation, the annular tear, the degenerated disc. Shot. And yeah, look at that tear. That's huge. Back there, you see it? Posteriorly. Give me an AP, please. Coker.
We have a question.
Sure. Yeah, what's the question?
We have a viewer who says, I have severe nerve damage in my neck. It's causing a lot of issues in different places.
Yeah.
I'd love to have surgery, but I've had one doctor tell me not to get surgery and another doctor tell me to get surgery. What would you recommend doing?
So, great question. We have a viewer who says, hey, I've got a problem in my neck. I know I've got some nerve damage. One doctor told me one thing, the other doctor told me another thing. So, the answer, you want my opinion, right? So I'll just say this. The problem you're having is so common. Literally every single patient I know, every one of them, has the same problem. And that is, you go to 2 different doctors, you're going to get 2 different opinions. You go to 3 different doctors, you're going to get 3 different opinions. You go to 10 doctors, you'll get 15 opinions. The point is that every doctor does things differently. And that's why one of the reasons we do this broadcast is so I can answer these questions honestly for you from experience of 22 years that I've been doing this. And I can tell you right now, it doesn't matter whether you're talking to primary care docs about what medicine you should take for your blood pressure. They're all going to have a different opinion. It doesn't matter if you're talking to a radiologist. Literally, you can have this MRI, this patient's MRI, okay? If I take this patient's MRI and I were to show it to 10 different radiologists, you will literally get 10 different reads because they all have different opinions, even though it's all objective, even though it's not even an essay. It's literally a multiple choice scientific fact. You have to pick, and it's clearly there's structural changes at each level. You're going to get 10 different opinions. So my point is, it's unfortunate, but in medicine, as in many things in life, depending on who you talk to, so I'm watching the tip, you're going to get different opinions, okay? And that's one of the reasons we want people to understand that Duke Spine Institute offers a free MRI review and a free video conference where I can sit there and talk to you after examining you over the video conference, over Skype. I can tell you what I believe is right for you, okay? And I can't answer your question because I don't know which doctor's right. I don't have enough information. The God's honest truth is I need more information. I need to see your MRI. I need to see the pinched nerve. I would love to get a nerve test to make sure it's being pinched in your neck. And then I could give you an opinion. And so I can do a review of your MRI for free if you submit your MRI. And so I'll just say right now, for those of you watching, Duke Spine Institute has its own app on Apple and on Android. And I strongly recommend everyone out there hearing this goes to your phone and downloads the app for Duke Spine Institute. It's DEUK Spine Institute. And it's going to be literally the best spine app you've ever seen in your life. It's amazing. I've seen all the spine apps out there. They're garbage compared to what we have. And we have information, detailed information explaining different diagnoses, all the different treatments available. You can set up an MRI request for us to review your MRI. You can submit your report, submit your images through the app. You can ask questions through the app. We have a Facebook support group for anyone that wants to join. It's pretty much open. just request the ability to join. It's called Spine Surgery Support Group. Spine Surgery Support Group. And in that support group, you can actually ask questions that everyone can benefit from the answers. I personally answer each question along with Dr. Patel, so you have leading experts in the field of spine answering questions. So really, our whole goal here at Duke Spine is to inform you of the truth of what's available, what's the problem, what you can do to fix it. And then we do perform the most advanced, state-of-the-art, safest surgeries in the world. You won't find better results anywhere. I'll just give you an example. I've done 1,000 ACDFs, anterior cervical discectomy and fusion. Okay? In 1,000 surgeries, I've never had any kind of life-threatening complication. I've never injured a nerve, never injured the spinal cord, never had an infection. I've had one hematoma, one blood clot, and that was about 15 years ago, and changed the way I did the surgery as a result, and I've never had another. And I think it had more to do with blood pressure after surgery. So I'm very careful about monitoring blood pressure in my patients after spine surgery, and most spine surgeons don't even pay attention to blood pressure. So there's so many little details that go into having good outcomes for patients. And honestly, I'll be honest with you, I talk to spine surgeons all the time. I go to meetings. Most of them just don't care. You know, they already know that some patients will die, some patients will be paralyzed, some patients will have infections. And they're like, if it happens, it happens. It's out of my control. No, it's 100% in your control. And I'm living proof of that. In 1,000 ACDFs, I've had one complication. Now, I've had a couple of screws that backed out of the plate, but that's not my fault. That was the design of the plate. And they backed out a few millimeters. Most of them weren't a problem. But I haven't had any screw backouts in the last 8 years because I switched the plate that I use. Long story short, my kid races cars, and when he started racing junior, which is the most aggressive category in go-karting, it's all 12 to 15-year-old boys and a few girls, and they're all high on testosterone, and those guys are absolutely crazy at the start of races. And there's so many crashes. And my son kept crashing out, and he came to me and said, "Dad, it's not my fault." And I said, "No, actually it is. You know, you have to learn how to position your go-kart at the start of a race so that you don't crash out. You have to create buffers on the side. You have to be braced for impact. You have to be ready for someone to hit the rear of your go-kart. So you have to have your go-kart perfectly positioned at the time of impact." My point is that people can control their destiny. If you take enough of an interest in it and you learn enough about the facts and the things that affect what goes on around you in your life and the people around you, you can control your destiny. You can change it, you can shape it. But it takes a lot of focus, concentration, willpower, desire, intelligence, experience. There's all those factors. So in spine surgery, it's no different. That's why we broadcast. We do this broadcast so people can understand there's a better way to do it. You don't have to accept complications. You don't have to accept dying on the table. I've never had a patient die on the table, never had a patient die as a result of my surgery. I've never paralyzed anyone, whereas many spine surgeons will have paralysis. They'll hit the spinal cord. As a matter of fact, the surgery you're watching right now, I wasn't the first to do endoscopic anterior cervical surgery. The Koreans were, South Koreans. And the reason they've stopped doing it is because they had several patients that were paralyzed. But now I do it very different than they do. And they do it with the patient awake, for example. I don't do it with the patient awake. I have my patients asleep and completely relaxed. And there's other things that they do in their surgery that I won't mention right now. But those things that they did, I didn't do it their way. I did it different. I did it my way. And by doing that, by making those decisions, I have better outcomes than the people who did the surgery before me, my teachers, okay? So you can always change what you learn in life and do it better if you pay attention to, well, what's wrong? What could I have done better? Where was the problem? And if you understand your problems that you encounter, you can then fix those problems. And so you don't keep having the same problem over and over again. All right, so we're now at 4-5, which is the second disc that we're going to fix. And we're going to make our way out to the foramen again. These are all, you can see, these are all fragments of herniation right here coming out. Okay? And most people might think of a herniated disc as, oh, it's one piece. No, it's many pieces. About 90% of the time, it's many little pieces, just like that one that we floated out. Okay? Rarely do you get a big chunk, right? And of course, every surgeon wants a big chunk because it makes our job easier. But in reality, it's usually a lot of little chunks like we're seeing right now. How's my irrigation? Good?
It's good.
All right.
We have
Yes.
a question.
Sure.
We have a viewer who's asking, if you're looking for a doctor to treat you, should you look for a neurosurgeon or an orthopedic surgeon, and what's the difference between them?
Well, if you're looking for a doctor to treat your spine, I think you should go to Duke Spine Institute. Okay? So, a lot of people want to know who's better, orthopedic surgeon, neurosurgeon. I would generally say neurosurgery is better if I had to just make a generalization. But the truth is I've seen orthopedic surgeons far better than most neurosurgeons. And I've seen some neurosurgeons who are just absolutely horrible at doing surgery. Horrible. They have like I won't even say, we had a neurosurgeon in my residency. I will not say his name. There's a herniation, by the way, out of the foramen. But his nickname was Lobster Boy. I'm sorry. I hope I'm not offending anyone. But when your nickname's Lobster Boy, it's not because you eat a lot of lobster. Okay? Just think about it. It's because his hands were like lobster claws. He was so bad at using instruments that they called him Lobster Boy. I didn't call him Lobster Boy. I would never say that to somebody. I think it's offensive. But that was his nickname among the mean residents in the program. They called him Lobster Boy. So, but I have to agree that his technique was not good. And this, I'm going to tell you something. I'm going to say this, and I hope he's not listening. I'm sure he's not listening because nobody really cares what I do. But this resident scored the highest score in the nation on the neurosurgery board exam. All right? The highest. So, complete brainiac. Very smart. And I liked him. I like him. But his hands are horrible. So what I'm saying to you is it doesn't matter neurosurgeon, orthopedic. What matters is the skill of the doctor you're working with. That's what matters. Forget about titles. Forget about degrees. Forget about where they trained. What matters is how good they are. What matters for every patient should be the outcome. What matters is how good you did, how good most patients do. What's the average? How do most patients do? Right? How many complications do you have? Somebody asked me just a minute ago about complications. Every surgery has the potential for complications, but what you really want to know is how many complications does your surgeon have? How often? Right? A lot? A little? And then what kind of complications? So I'll give you an example. There's a hospital that I've done surgery at. Oh, this is driving me crazy. Go ahead and wipe. Sorry, there's a piece of tissue that was stuck to the laser and it was just obscuring my view, so I had to get rid of it. Anyway, one of the hospitals that I've done surgery at for years, and this is one of the reasons I stopped going to hospitals for surgery, okay? Because when I first started, there was all the anesthesiologists were doctors, MDs, and they did a great job. But then the insurance companies talked to the hospital and said, we don't want to pay the medical doctors so much. They cost a lot of money. We want patients to get cheaper care. So we want you guys to get rid of the anesthesia group of doctors, and we want you to hire a bunch of nurses to do the anesthesia at the hospital. So what do you think the hospital did when they were told to do this? They listened. They did what, and I just tell you, at Blue Cross, and I know this because I was the chief of staff for 2 years. So I found out that Blue Cross told them, hey, you guys need to cut some costs here and save us more money. Even though Blue Cross is making hundreds of billions of dollars a year in profit, they wanted more. So they forced the hospital basically to get rid of their medical doctors. The insurance companies forced the hospital to get rid of the medical doctor anesthesiologists and replace them with nurses. And I will tell you, I have a lot of nurses in my family. I love nurses. But in my opinion, most nurses that do anesthesia don't do it as well as a doctor, as a medical doctor, period. So I'm a big believer in quality and not cheapness. I don't believe you should go cheap in medicine. I think you should go with quality. And so you get what you pay for. All right, Luis, what's going on here? Did I adjust the focus or what? I think we may need another scope. We may have a problem with the scope. Right?
Go back there, right here. There is another cervical scope.
Standby laser. Take this.
Yes, sir.
Well, there goes $5,000 down the drain.
What happened?
I
It's
don't
working
know.
fine.
Let me see. Yeah, it was working fine, but I think
Do we change irrigation
I've-
full or
no, it's not that. It's
is the camera or?
I don't know. I've looked and I don't see anything that I can fix. It may have to go to Germany for repairs
Alright.
because I can't see anything. Let me wipe the tip.
It's right there. Right there. Right. I put one there just in case we need another.
Yeah, that's exactly what you have to do, Luis. You have to be prepared. All right. Yeah, I'm adjusting the focus and I'm not seeing any improvement. Now, it's either the scope or the camera. So let's try a new scope.
Yeah.
If that doesn't work, we'll try a new camera. So, sorry about the delay, but like I said, this is a live broadcast of surgery, and I can't prevent everything from happening that shouldn't happen. Just take your time. Let's get some lights on. Make sure she can see what she's doing. Let's get the scope, the light off for the scope. You have a question there?
We do. We have a viewer asking, after you remove the disc material, do you add anything back in to fill the space and hold it together?
So after I remove the disc material, do I add anything back in to fill the space? The answer is no. I'm not removing normal disc material. Whoa, 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 whoa. What is that? Let me see. Could that? No, the camera looks good. Yeah, the camera's got a beautiful, can't do that. Got a beautiful image. So it's got to be the scope. There's nothing to fill in, folks. What's happened is it's kind of like there's a tear and then the jelly from the center squeezes out. So there's no filling anything in. There's going to be a gap there, and the body will actually heal that gap on its own with collagen. So the annulus itself is made out of collagen. So the annulus, the white annulus is collagen, primarily collagen, some elastin. And when we take the herniation out, that's the part that sticks out. It's going to be replaced in time with collagen. So that's exactly what the nucleus was made. I'm sorry, the annulus was made out of it to begin with. All right, much better. Sorry, we just had to change the scope because the scope stopped working. And yeah, that's not going to be cheap to fix. All right, laser's back in. Are you guys watching again? Zach?
Yes, sir.
All right. So we're back in. We'll just adjust the focus. And we need to get that scope out today
Yes, sir.
to get it repaired.
Yes, sir.
Not having a great picture here, but definitely better than before. I don't think this scope is that good either. We need to have this scope looked at. We're going to have two scopes looked at by Germany. Okay?
Yes, sir.
Now, I'm not happy with the quality of this picture either. It's not horrible, but it's pretty close. Let me see if I can make it any better. I wonder if part of it's my zoom. Let's get a little more light. That's good. How many did you go up? 2 or 1? Yeah. Luis, I like that other scope better. So that other scope had a nicer picture. So this is the foramen. Now the question once again, Zach, I don't know that I answered it completely.
The question was,
Do you have another scope?
Yes, yes,
This is our only cervical for today, right?
yes, sir.
There's
The
a little
question-
fragment of herniation right there, folks. You see that? Go ahead, Zach. I'm listening.
the question was, after you remove the disc material.
Yeah, okay, sorry. Yeah, I remember now. So after I take the disc herniation out, is there anything I put in? No. There's nothing to put in. There's no reason to put in. I could start putting things in and charging more money, but honestly, why? There's an old saying, why fix something that isn't broken, right? So why should I change what I do if it's working fine? There's nothing to put in, folks. Nothing. It's just the body will heal it, and it's done. Yeah. The reason why you don't want to put anything in, just so you know, people have tried it before. Not me, but other people. And what happens is you end up with, that thing that you put in ends up dislodging, and then it pushes on the spinal cord and paralyzes the patient. And you don't want that. All right.
We have another question.
Sure.
We have a viewer who says, I have
You
a
have another
herniated
one?
disc at L4-5 compressing on the nerve, causing leg weakness and toe movement at a grade 0. If the
Wow.
laser surgery isn't an option, what would the next best surgery be?
Well, so somebody is saying they have herniation. Let's turn the light down a little bit. They have a herniation in their lower back, and as a result, they have leg weakness with drop foot, it sounds like. And they want to know if the laser surgery is not an option, what would be the next best surgery? First of all, I would say the laser surgery, Duke laser disc repair, number 1, 2, 3. But if you want me to keep going past 3, I'd say 4, 5, 6 as well. And then when you get to about number 8 or 9, maybe a microdiscectomy. If you have much back pain, I assume there's not much back pain. If there's much back pain, then a microdiscectomy won't fix the problem. You'll need a discectomy and a fusion. So I'm actually going across the disc to the opposite side, and all that looks pretty good. There's a piece of herniation there I'm going to go grab. You know, we can have that light on back there so we can see something. Yeah, it should always be on. I don't know why we're changing what we do, but we've always had that on in the past. Let's keep that on so we can see.
You want to change out the scope then?
I do. I do want to try another one since we're doing this. Yeah.
And this case was not the decompression, right?
Why not?
Huh?
Why
No,
not?
what I'm saying, the quality of
Oh,
the images.
right.
Yeah, just like
Right?
last time.
Yeah, that was funny. Last time when we had that white color, and I'm like, what is that? It was Depomedrol. That was interesting, wasn't it? So, I'd say microdiscectomy, possibly a laminectomy, possibly a fusion. You know, it depends on who's doing it and what they're doing. I personally don't like microdiscectomy. I hate it because you have to remove part of the facet joint. The facet joint is what holds your spine together. And once you start removing that facet joint, you're going to weaken your spine. It's going to start wobbling around. you're going to start getting more back pain. You're going to get another herniation. It's just a bad surgery. But so that's why when I say what's the best, you know, number 1, 2, 3, 4, 5, 6 is Duke laser disc repair. It's really true. I mean, the difference is dramatic. It's like, well, I'm going to go to war. I guess should I fly a crop duster into a dogfight, or should I fly an F-16? You know, there's such a dramatic difference in the quality of the treatment. It's literally scary to go back to the old technology, doing it with removing bone and all the ligament, because that just weakens the spine.
You have another one if you want to switch.
Yeah, I think we're just about ready to get out of this disc. I think there's just a few more pieces, that being one of them right there, and then we're going to go to our last disc, which is C67. Is our next patient here and ready to go?
He's here?
Yeah.
Yeah.
Is that Ann?
Yes, sir. Yeah.
Hi, Ann. How are you? How are you? Yeah, good. No, I'm not. I'm not needing anything, Ann. Don't worry. To me, that looks like a chunk right there. As my son would say, a chungus disc fragment. There it is. All right. Like I said earlier, these pieces of disc herniation come out in multiple little fragments, about 95% of the time. Rarely do you get one big old fragment that's really nice and easy. Most of the time you got to work pretty hard to get it all out. And that's true for any type of surgery, whether you're doing the endoscopic surgery or you're doing the open surgeries, a microdiscectomy. You've got to really, that's pretty cool right there, huh? You've got to really take all the pieces out. But honestly, I think it's easier endoscopically, in my experience. And I've done many hundreds and hundreds of microdiscectomies prior to doing endoscopic surgery. So I know, you know, just how damaging and destructive that surgery is to patients. I would wish it on no one, because it's basically, once you start removing all that lamina and facet, you're going to be bringing the patient back again in the future and doing more surgery. It's pretty much a guarantee. Rarely does anyone actually have long-term symptom relief from a microdiscectomy. Symptoms almost always come back.
We have a question.
Yeah.
We have a viewer who says, my doctor is switching me to a new pain medication called levorphenol.
Uh-huh.
I'm very uncomfortable with my doctor's decision. What is your opinion on that medication, and what would you recommend doing?
How do you spell it?
Levorphanol.
Yeah, this is the same question we got last time. I have no different opinion. I don't do pain medication. I don't think pain medication is the right way to treat pain. You don't want to be on pain medication. It's not proper. It's totally wrong. That's like treating a fire by throwing gasoline on it. It's stupid. Fix the problem. I'm not here to lie to you and tell you to do something dumb. I'm going to tell you what I think is best. And treating pain with narcotics, chronic pain with narcotics, is wrong. It's just not acceptable anymore. It never really was. The problem was that so many primary care doctors made a lot of money on chronic pain patients, just coming in for 5 minutes and getting a refill, and then billing $100 and making $100 for it. And that's why our country is full of junkies. You know, that's why we have so much death from narcotics that are prescription narcotics. Yeah, I'm not against narcotics, trust me. I'm against prescribing them improperly. And that's definitely a problem. So you're not going to get my support to take a narcotic. So I'm not going to tell you what do I think about that particular narcotic. I think that's the wrong strategy. I hope I've made myself clear. So if you happen to watch any more of my surgeries, don't ask the same question again, because you're going to get the same answer, because it's just me, Dr. Duke Majan, doing the surgery. Okay? There's nobody else, so you're going to get the same answer from me every single time. Yeah. Narcotics are fine to take after a spine surgery, like an open surgery. Woo-wee! Yeah. All right, that's not the problem. Stop. The problem is, stop. You don't see the problem? Right. So, here's what we need. We need a drape to go over the fluoro, one of those, okay? And then we need a blue towel, like a half sheet, to go over here. You got to figure this stuff out, Luis. Honestly. You know what I would do? I would cut the frickin' drape so that it goes on the side of the C-arm, so the tube can go down and drain the water. Because every time you leave the drape intact, it just creates a fold that holds the water. So Sue, my left foot is now soaking wet, but that's not the big issue. The big issue is that we have a exposed C-arm. Where is the shower cap for the C-arm? Let me have it. Let go. You have a stapler or some non-penetrating towel clamps? I don't want it. It's too late. Come on, Luis. You got to be prepared, Luis. You know, you really got to be prepared. I said I don't want it. Now you've just wasted, what, 20 bucks? Luis, you're making me feel like I should just try to operate without you. Honestly, you're not listening to me. I told you snaps, towel clamps. Do you not understand? What do Let me have the dilator. Fluoro. Jordan, why did you leave the room? Huh? I can't hear you.
I was told to grab towel.
You were told to grab towel clamps. Who told you to grab towel clamps? Give me a fluoro. Well, that was the wrong decision. We need Jordan here helping us with the fluoro. Shot. You need to have your nurse prepared. Has Luis taken you into that room over there and showed you where everything is?
They know everything. They know.
Do you know where everything is over there?
I'm trying to find it. I have not.
Has Luis taken you there and shown you the SPD where everything is? I need light over here. I'm sorry, folks. I am allergic to one thing, and that is incompetence. Everyone wants to work with me and do great things, but people don't want to take the time and to actually invest and make sure they do it right. Okay, shot. 2, 3, 4, 5. Yeah. I didn't become as good as I am by accepting failure. And I can't make people do their job right. They have to choose to. So when people choose not to do their job right, it's not my choice. I could choose not to work with them. But I usually believe in giving people at least a few fair chances. We need a shoulder pull. We need to see down to C6, 7. Is that understood? So start getting ready to position your fluoro. Let me see what we are. Go ahead and move south. Remember when we can see C6, 7 earlier? What were we doing different? 2, 3, 4, 5, 6. All right, just stay right where you are for now. I want to go ahead and get out of the disc space and move south. Shot. As I said earlier, folks, we don't edit these videos, and they are reality TV. Shot. So all I can say is if you don't like it, just turn us off. We're not here to be politically correct or sensitive. We're here to do great surgery and have great outcomes. Shot. I think we need an AP. It looks like we're off to the side a little bit. So Luis, you need to be better prepared for that scenario. Has that ever happened before?
This right here?
Yeah. No, has that ever happened before? Where?
Before, I remember, yes, sir.
Yeah. So, do you need to be prepared for a volcano erupting in the operating room?
No, sir.
No. Do you need to be prepared for the shot? All right. What's that? Get this. Go lateral, please.
We have a question.
Sure.
We have a viewer asking, how soon after the surgery can you go back to playing sports?
How soon after the surgery can you go back to playing sports? Great question. It depends on what surgery is being done, and it depends on, I'm getting too much resistance from the muscles in the neck. I'm getting a lot of pushover. Shot. It just depends on what sport, and it depends on what surgery. How many discs? Shot. It really depends on a lot of things. So I need to know specifically what sport you're talking about. Shot. I need an AP view. Shot. All right, good. I actually fell back into the annulus there. Let's go, Jordan. Shot. All right. 2, 3, 4, 5, 6, 7. Okay. So, sorry I can't be more specific about sports. Shot. It just depends on what sport, AP, and Everyone's a little bit different just because of their anatomy, their physiology, how quickly their tissues heal, how bad the herniation is. There's too many variables to discuss it all right now. I would need to know how many herniations, cervical or lumbar. I would need to know how big. I would need to know what's the main problem you're having. Is it radicular, myelopathic? What is it? Is it pain, shot? All right, need to get back to the midline. Stay there. Shot. Lateral. I need to know what sport. I need to know how aggressive, like what level of play. Are we talking pro? Are we talking semi-pro? Are we talking, intercollegiate? What are we talking about? 2, 3, 4, 5, 6, 7. Every sport's different. And is there a specific sport, shot? Nice. I can feel the herniation. Shot? I need an AP.
They're asking about football.
Football. All right. And is it a cervical or a lumbar? Neck or back we're talking about? Let's go, Jordan. All right, so we're a little bit off to my side. Yeah, I just need to know if we're talking about a cervical herniation or a lumbar herniation. Shot. All right, let's go lateral. It's looking pretty good right there. I just need to see where we are on the lateral view. You got inline traction? Shot. Damn, we're off. Oh, why are we off like that? Shot. No, shouldn't be. AP.
They're asking about lumbar.
Before you can go back to full contact, you're going to have to wait probably 3 to 6 months. Now you can go back sooner, but the sooner you go back, the more chance you're going to have of re-injuring. Get this thing out of my way. Shot. That's what I'm talking about, okay? We got way too much muscle tone. Shot. It's pushing my thing over. Shot. Lateral.
Dr. Santoro, can you please put a standby the light at the frame now, please? You see the bottom on the bottom? The light?
Shot.
There you go. Perfect. Thank you, Jordan.
Shot. Keeps going to the same place. AP. Wait. Shot. That's better. Give me a quick AP. How are we doing on muscle relaxation? I know there's no twitches, but we need more than no twitches. We need no movement, no contraction at all. So we know from open surgery that we can get twitches, right? Shot. Shot. All right, lateral now, quickly. Don't move anything. Mallet. Quick lateral. It's moving. Again. AP. Get these things out of my way. Let's go. Huh? Yeah, but it slid a little bit to my side. not wanting to stay. I can feel a bone spur. Shot. Shot. I'm gonna have to radiate my hands. Shot. Lateral. Shot. Pallet. Shot. AP. It's good. Stay, go back to the lateral. Okay. All right. Shot. Shot. Well, Jamie, and that's all I can say. We almost had to not do this level. Shot. 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 Interesting. Shot. Well, that's not good. I'm not going to be able to get our discogram done. Shot. We're definitely in good position, but can't seem to get the end of this. Shot. Oh well. I'm not going to be able to do a discogram. No. Let me have the tubular retractor. So this is our third and final disc we're doing. We've done C4-5, C5-6. This is C6-7. 2, 3, 4, 5, 6, 7. Just to verify it. C6-7 is the hardest disc to get to in the front, besides C2-3. And the reason for that is it's the lowest in the spine and the neck, and it's right above the collarbone. And a lot of times the collarbone is going to block the access to the disc through the front. Shot. You can actually see the collarbone in this patient is literally just below the tube. It's that dark shadow. Shot. All right, so I'm advancing the tubular retractor through the disc. Shot. Pretty close to being right where the foramen is. Shot. There we go. I'm just outside the foramen. Any questions from our audience? So there's bone in there. There it is. A little bit of bone and some ligament from going through the anterior part. Okie doke. We are ready to get started on our last disc. Any questions from the audience, Zach?
Not yet.
All right. So once again, you're watching the most advanced spine surgery in the world for treating cervical disc herniations. This is far more advanced than your fusion surgeries or your artificial discs. If you understand the development of surgical technology when it comes to orthopedic problems, you'll understand that we started treating bad joints with fusion many years ago, right? So if you had a bad knee or a bad hip, you were going to get a fusion a long time ago. Then surgeons quickly figured out that, sure, the fusion will take the pain away, but you lose movement. And they started to develop artificial hips, artificial knees, basically artificial joints made out of metal and plastics, right? So you got artificial hips, replaced hip fusions. Artificial knees made out of metal and plastic replaced knee fusions. And people were able to get rid of pain from arthritis, and at the same time they were able to did you try a new scope yet?
Yes, sir.
This is the new one?
Yes, sir.
All right, thanks,
It's
sir.
very
You gotta let me know. I'd have to adjust the focus. I think that last one was probably, the first one we had was probably the best one. Yeah.
I'm gonna.
Let's go a little bit brighter. A little bit brighter. Actually, that's pretty good right there. This is a good scope. I think those other two need to be sent in.
Not a problem.
Yeah. Let's get them in, get them repaired, whatever they need to do.
Yes, sir.
Hopefully they're going to still maintain them for us. Right? Wolf is a little screwy. This is a nice soft disc. You guys get to see what it looks like without the blue dye. Yeah, I don't like doing it without the blue dye because you can't see the degenerated disc as well. But you can't see the anatomy as well. But we don't have a choice. We're stuck. Either we don't do it at all or we do it without the blue dye. And I think it's better to do it without the dye than to not do it at all. That's the end plate. Here's the foramen over here. So we've got another 10 minutes and we're done. Okay? Grab her. Dr. Santiago, you got me?
Yes, sir.
Another 10 minutes and we're done. There's a definitely a, I would love to be able to grab that piece out. I just think it's stuck down from scar tissue from chronic inflammation. That's a piece of herniation though. Oh, I might have gotten part of it. Zach, more questions?
Not yet.
All right. Well, you're welcome to ask questions. Laser. I tell you, look at that guy. He's playing games with me. So sometimes herniations are too big to get out with one piece. You just have to break them up with the laser. That's a piece right there. I mean, pretty big. Well, feel free to ask questions. We got about 10 minutes left in this surgery, and then I'll head over to the conference room as I always do, and I'll answer some questions you might have as the audience. So this would be a really good time to ask those questions. I'm working on the annular tear and what's called the interposed disc herniation right now. So when you don't stain the herniated disc blue with the dye, which binds to herniated degenerative disc, then it's white, as you're seeing right now. And this is true for the cervical and lumbar spine both. In other words, the neck and the back both. And I keep floating little pieces of herniation out. That's pretty much what I'm doing. And I apologize that you all can't see better, but it's the best we can do right now. In surgery, you have one shot, that's it. We don't edit and we don't reshoot. It's not a movie. It's reality, you know. We can't go back and change what we did and try to do it different. You've already done what you did, and there's no going back. So we haven't done anything wrong. I'm just thinking it'd be nice if I could have gotten that dye in, but there was no way. It wasn't going. So this is the foramen on the left side at C6-7. I've gotten most of the herniation out. It was a big chunk.
We have a question.
Yeah, sure.
We have a viewer who says, I have nerve damage and degenerative disc disease at L45S1.
Yes.
What can you do to fix that?
Oh. So nerve damage and degenerative disc disease. So I'm going to presume that your nerve damage is from the degenerative disc disease, that you have a pinched nerve. What we can do is we can do the laser surgery, just like you're watching here, except for the lower back. And it takes an hour to do, and there's done through a 7mm incision. It's tiny. Outpatient surgery, and we have a 95% success rate of getting your nerve function back. And I don't know what kind of nerve damage you have or how much nerve damage you have, but if you have a pinched nerve, you need to get it unpinched. And this surgery you're watching, the Duke laser disc repair, is literally the best there is. That being said, I can do any surgery you want. You want the traditional microdiscectomy, we can do it, but I wouldn't recommend it because you're taking bone out and it's not as good of a surgery. If you want a fusion, I can do that too. If you want an artificial disc, I can do that as well. So whatever surgery is wanted can be done, but you want the best, it would be the Duke laser disc repair, which is endoscopic surgery. Then there's no bone removed, there's no destabilizing the spine from the surgery itself. It's just really nice and a very quick recovery. Literally a few days, you're back to feeling great. Most patients feel immediate relief right after surgery. It's kind of nice when we do these surgeries, we can record them for our patients and they can actually watch the surgery after their surgery. Usually at night, they'll watch their surgery, that night of the surgery. And they come in and see me the next day and say, wow, that was amazing. I got to watch the surgery. That was so cool. So people kind of like learning themselves about what they had done. And so I'm out in the foramen, kind of like I was before, under the root. There's end plate to the left, end plate to the right, uncovertebral joint at 12 o'clock, just past the laser. And I've gotten the foramen decompressed. This piece is killing me. Go ahead. Wipe it. Alright. There's a little piece of disc material stuck to the laser and it's obscuring my view. It's just annoying. Believe it or not, surgeons like things to be pretty much the same every time they do surgery. They don't like variation. And rightly so. We don't like surprises. We like things to be predictable, just like most people. When you have a predictable surgery where everything is the same, then you get predictable results, right? Everything stays the same. If you have great results, you want those predictable results. You don't want to deviate. You don't want to have good results one day and bad results another day. You want to have good results all the time. So the more you can make the surgery the same when you're treating the same problem, the more predictable your results become. And that's what I've learned. We're done. Thank you, everyone. Let's shut the scope down. And I think this scope's fine, Luis. I think the other two we should send in. Yeah. We should have still 3 more, right?
So I'm gonna check all of them to see.
Well, I just say send those 2 now.
Okay, not a problem.
And let's see what happens. All right, we've lost, I'd say, 5 mils of blood at most. No, that's for the back, never the neck. I'm going to take the tube out, Zach, and then you can show our viewers what hole we used, how we did the surgery. Take. Okay, can show our viewers what we did to do the surgery. You want to get that out there? Yep. So you want to zoom in here? The reason I'm holding pressure on the incision is sometimes you get a little bit of venous bleeding, and venous bleeding comes from a tear in the vein. It's very common, expected. It's not a complication. Having bleeding during surgery is not a complication. Having too much bleeding is a complication. Having symptoms or findings as a result of too much bleeding, like a heart attack or something, is a complication. But having some bleeding during surgery is not a complication. So here's the incision. You see that? Can everyone see that? Zach, you see it? It's
We see
literally
it.
4 millimeters. And we fixed 3 discs. And again, this is the most advanced spine surgery in the world you're watching. Here in Central Florida on the Space Coast, Duke Laser Disc Repair. If you don't want metal in your neck and you don't want to lose movement, this is the surgery for you. Okay, you got this? Pressure for another 2 minutes, and then you can put the bandage on. Let's get our questions loaded up. Audience, if you have questions for me, feel free to type them up. Happy to answer them. Sometimes during surgery, it gets a little stressful, and I can't answer your questions, but after surgery, generally, it's not so stressful. It's a good time to answer them. All right, so this is a DLDR, right approach, C4-5, 5-6, 6-7, and you did an RFA. Which side? Left? And that was what? C4 to 7? Perfect. Our EBL is 5 mils. I don't think it was even 5 mils, but we'll just put 5 mils. I think it was not quite that. Great job, everyone. Thank you. Luis, learn from your experience. And it'll make you a better person and a better assistant. Good job. I'm going to go see the next patient. Thanks everyone for watching. I'll head over to the conference room in a few minutes and answer your questions. Once again, I'm Dr. Ara Duke-Machen, CEO and founder of Duke Spine Institute and the Duke Laser Disc Repair. Okay, Dr. Dugmajian back with you. Zach, you're on the cable. Thanks. For those of you still with us, I'm Dr. Ari Dugmajian. We just finished a Duke laser disc repair. Duke for Dr. Dugmajian and Duke Spine Institute, where it was created. Laser, because we use a laser, obviously. That was the blue fiber, white clear fiber that you saw. It stayed at about 12 o'clock, the whole surgery, if you go back and watch. Disc, because we're fixing a spinal disc, and repair, because we're not fusing and we're not putting an artificial disc. Basically, those surgeries like fusion, artificial disc, they take the disc out and get rid of it. You're throwing it away. And it doesn't matter that 95% of the disc is normal and still working fine. It doesn't matter that 95% of the disc is not causing a single problem for you, the patient. They take the disc out. It's gone. It has to be scraped out in order to get back and take the herniation out. The reason why is simple. The instruments and tools that are available that most surgeons use on the spine don't allow the surgeon to pass through the disc, leaving it alone and just taking care of the herniations. Literally, when you're doing an ACDF, I hope you watched one. We have them online. You can go back and see it. It's very different. You're slitting the neck open. You're going down to the front of the spine, and there you see this disc. But you see the front of the disc, and you need to see the back of the disc. So the only way to see the back of the disc is to remove the front of the disc, which is the entire disc basically, and then work through a little space between the two vertebrae. And when you're done getting that herniation out, you got to put something back in that empty space, and that's where you put an artificial disc, or you do a fusion with a cage and a plate. You only do that because there's a gap there, and there's only reason there's a gap there is because you took the disc out so you can get to the piece in the back and get it out that's pinching the nerve. So with the endoscope, you're able to go in and get that piece out without taking the whole disc out. And so you don't need to do a fusion. You don't need to put plastic or metal or cadaver bone in the patient's neck. So it's a much better surgery because it's much more natural. And I was talking to you a little bit in the operating room before things got a little, a little bit more intense and required more of my focus. I was talking to you about the evolution of the treatment of diseased joints in the human body over the last couple of 100 years. And when people had painful diseased joints originally a couple 100 years ago, surgeons found that if they fused the joint together, so they fused the bone above and below the joint, that they got rid of the pain. But the patient couldn't move. So if you're fusing a knee, you got a straight leg then, you're like walking on a pogo stick. And so guess what that does? That's all good and fine for a few weeks. But you're changing your biomechanics of your gait and your station, and that's going to have effects on other joints and muscles throughout your body. And so what ended up happening when you fuse a knee or a hip in the old days is the patient walked with a stiff leg, and basically they ended up having problems everywhere else, like the other knee, the other hip, their ankle hurt, their back hurt. So you took away one pain, you created like 5 new causes of pain. That's when you fuse knees and hips and joints. Well, spinal fusion is not as bad as that, but you're still losing movement, right? And you're really putting a lot of strain on joints above and below the fusion to wear out. So along came artificial disc technology, which is basically artificial joint. It's the same as an artificial knee, artificial hip. It's an artificial joint, and the joint is the disc joint. And so you're basically replacing one of the joints of the spine, called the disc, with a metal and plastic disc. You're still leaving the facet joints there, which are also causing pain, so you're not really treating all the causes of pain when you do an artificial disc. So artificial joints allow preservation of movement at that joint, but they relieve pain because you've basically gotten rid of the painful joint by eliminating the space and everything in between the joint and creating a metal joint which doesn't have nerve fibers attached to it. So you're not ever going to have pain from an artificial joint unless, of course, the joint bone interface develops issues or you get loosening of the implant, so that can cause pain. But otherwise, the joint itself is not painful. So over time, someone developed what's called endoscopic techniques. So there was a transition in orthopedic surgery treating knees and hips, shoulders. It went from fusing the knees, hips, shoulders to putting an artificial disc to finally doing endoscopic surgery, where we can go in with a tiny incision and go look inside the joint and repair a tendon or a ligament or a cushion like a meniscus. you can actually do all that with a tiny incision. So you don't have to do a fusion. You don't have to do an artificial joint. You do a repair. So, of course, when spinal arthroscopy came out, and I wasn't the first one to do spinal arthroscopy, there are many people ahead of me that did. But what I did was I took it and applied it to the cervical spine, and there had only been a few surgeons in the world that have ever done the cervical spine. The ones who have done spinal endoscopy surgery have typically done lumbar spine because it's safer and easier, but cervical spine is harder, more complex. But I wasn't the first one to do it. There were other surgeons like Dr. Sebastian Reuten in Germany and Dr. Sang-Ho Lee in Korea and Dr. Gun Choi in Korea. They were my teachers. They taught me. I had to travel overseas and learn. Well, I learned the basics of their technique, and then I thought about every step, and as an analytical surgeon, as a scientist, I modified things, and I changed it to what I thought was better. Kind of like developing a Formula One race car, right? You can develop the chassis and the aerodynamics. You can develop the engine, power unit, battery. So you take something that already exists and you make it better by changing the structure, changing the form. And that's what I did. I created the Duke laser disc repair. And if you put the Duke laser disc repair against every other endoscopic surgery, it is far better. It is far better. And believe me, if it wasn't, I'd figure out why it wasn't. I'd go change it so that it incorporated elements of other surgeries that made those other surgeries better. So then, once again, this surgery would be the best. And I don't do it for an ego purpose. I do it because I want my patients to have the best. I don't want to treat a patient with surgery and then, a week later find out, I'm still having pain, or I'm having this problem or that problem, and I could have done things different during surgery and had a better result for the patient. For me, it's all the same in terms of financially. I get paid the same. Time of surgery is about the same. So there's really no impact on me. But when you want to improve a process, what it really impacts is the people who are impacted by the process. And by changing the surgery like I did over years and making it better, I made it better for patients. I didn't make it better for me. I didn't make it better for my equipment or my meds or anything. I made it better for the patient because the patient had a better outcome, a safer outcome. And I think that's what a responsible good doctor would do, is they'll look at how they treat patients, their diseases, and they'll say, how can I do better for the patient? Not how can I do better for myself, how can I do better for the patient? And what that does is it really puts the patient back where they belong, which is at the very center of healthcare. The patient becomes the reason why we do healthcare, and that's always been traditionally why healthcare was done in the very beginning, whether you want to go back thousands of years or you want to go back hundreds of years. The reason to do a medical or surgical intervention is to help a patient. It's not to help the doctor, the hospital, or the insurance company. It's to help the patient. So I think we've lost track of that. When I say we, I mean collectively we, as in physicians, hospitals, insurance companies. Of course, insurance companies were never putting the patient at the center of healthcare. Doctors did, nurses did, therapists did, maybe even hospitals did a long time ago. My dad was a doctor, and I know he always put the patient head and shoulders above everything else. And he always told me, he said, the way you become a successful doctor is to always do what's best for the patient. Because I asked him, I said, Dad, how come you're so successful? He was an OB-GYN. He's no longer with us. He passed away, but he was an OB-GYN. And he literally had the busiest, best OB-GYN practice in the entire county. This was back in Thousand Oaks, California, where I grew up. Okay? And everywhere he went, patients followed him. They loved him. Hospitals loved him because he did a lot of business for the hospital and made him a lot of money. But for his standpoint, all he cared about was that doctor-patient interaction and relationship. Being of service to the patient, fixing a problem for the patient. And I asked him and said, Dad, how come you're so successful? How come you're more successful than all the other OB-GYNs? And he said, it's because I basically put the patient first and take care of the patient and do what's right for the patient. And he never saw it as a chore. He never saw it as something that required effort. He just did it effortlessly. And he would come home from the hospital at 2 in the morning or 3 in the morning, delivering a baby, taking care of a woman who's having bleeding or some problem. And he never complained, not once, about the work or the workload. And of course, I thought every doctor was that way. And then, of course, I became a doctor and I learned they're not. And I've learned to be honest with you, as I speak candidly on 9/19/2019, I absolutely hate most neurosurgeons and orthopedic surgeons. I hate most doctors because I have no respect for them, because they're not real doctors inside. On the outside, they may have a certificate, they may have an office, they may have patients, they may have a stethoscope, but inside they don't really do what's best for the patient. And I've seen it over and over and over again, and it's jaded me. And honestly, I'd still go into healthcare because of what I do for patients. But I always thought, doctors were pretty cool people in general, but I've learned that they're not. And I'm not happy with them because they don't put the patients first. I've seen doctors sell out to insurance companies and lie and give opinions that patients don't need medical care when they do. And it's obvious they do. But the doctors are being paid. Their bread is being buttered by the insurance companies who want them to say the patients don't need care. So yeah, I'm pretty upset about the whole healthcare system as it is. I see narcotics being taken away from patients who really need them. Patients who have had surgery or fractures. Patients who have been in auto accidents are in so much pain. They need those narcotics, but they're being taken away from them. Why? Because of special interest groups that have other agendas, that don't care about whether patients are suffering. So yeah, I'm pretty frustrated with the entire healthcare system. And I think, honestly, you should be too. Those of you listening, you should be frustrated. You should be angry. But the problem is that nobody wants to do anything to fix the healthcare system. And they're leaving it up to politicians, or worse yet, they're leaving it up to the insurance companies. The insurance companies will never fix healthcare. They're the reason healthcare is so bad, because they're in the position where they can deny any treatment or any test that the doctor orders. And that's exactly what they do. And they found that over the years, there's no accountability for them to deny medical care or treatment for patients unless someone sues them. And finally, thank God, people are starting to understand that. So today it was announced, actually yesterday it was announced in the afternoon, that the American Hospital Association, who has sued Medicare, the biggest insurer in the United States, it's controlled by private insurance companies. Well, Medicare, aka the private insurance companies, tried to take away what's called the site of service differential payment for outpatient services. So what that means is hospital doctors get paid a little more than doctors like me who are not hospital employed doctors. And they get paid a little more because the hospital supposedly has higher overhead than we do. So Medicare, the private insurance companies, that control Medicare, said, how can we make more profit? Because we're already making billions, but we're so filthy greedy and we have no conscience whatsoever about suffering Americans or people in the world. How can we squeeze more money out of the healthcare system? Because hundreds of billions of dollars a year in profit is not enough for us. So one of the ways they devised, or one of the things they devised, the scheme they devised was, hey, let's take away the site of service differential in payment for outpatient services that hospitals enjoy and get because they have a higher overhead than, say, a practicing physician in private practice. And that's what they tried to do. And so they stuck their hand back in the cookie jar and tried to take more cookies out, basically try to clear it out so nobody else could have a cookie. And the American Hospital Association said, we're suing you. And they just won in federal court with a federal judge who said that the government cannot take away that extra payment they were getting, and they've been getting since the beginning of time, or at least since the beginning of Medicare. So that judge made the right decision, I believe, because what's really happening is the private insurance companies are using Medicare as a front to make all the changes they want, because they always piggyback on Medicare. And for example, I'm going to give you a big example that's a real problem right now, and it's been a problem, and I noticed it before when it first started happening and before it even happened. But nobody else notices these things for some reason. And we've got a lot of smart people, but they're all focused on the wrong issues. So one of the things that's happening is the insurance companies are basically denying care and denying payments. And so one of the things that's been happening is that they have been reducing our reimbursements and denying procedures, denying testing, denying authorization, and then on the back end denying payment. And so these denials are out of control, and there's absolutely no one that's going to hold them accountable except for the public, which is why I'm talking about this, because I'm talking to the public right now. So I'm making the public aware of the fact that if you don't restrict the insurance company's ability to use Medicare, for example, to reduce reimbursements for services you're getting, there won't be any hospitals or doctors around soon to take care of you. And that's just fine for the insurance company, because the insurance company, if they get rid of 99% of the doctors and hospitals today, they're still going to charge you the same premium, even though you won't be able to get in and see a doctor for 2 years, 2-year waiting list. So their premiums, co-pays, deductibles have not gone down, even though doctors have seen a 40% on average reduction in payments from insurance companies over the last 10 years. So a lot of people don't know this, but it's a fact. So we're being taken advantage of, and the only way it's ever going to get fixed is if the public does something. What do I want you to do? What do I think will work? I know it will work. I'm sure of it. Insurance companies cannot have the ability to deny treatments or care that's recommended for a patient, that a patient wants to get by their doctor. And that's what they're doing. They're denying it. They're denying anything a doctor recommends. They're doing it because they've gotten away with it, and nobody's held them accountable. Nobody's stopped them. There's no laws that are preventing them. And the reason for that is simple. They've engineered our legal system that way. The insurance companies have had a powerful lobby in Washington, D.C., and in every state government for the last 30 years. And as a result of that, the insurance companies are like cancer. They literally go to the vital organs, so our political system, and they've been writing laws silently and quietly with the assistance of certain politicians that they've lined their pockets with millions of dollars, and the insurance companies, through lobbyists, of course, not directly because they would never want to be culpable for what they've done, they have basically written state laws and federal laws allowing them to deny treatment, which was never allowed before. And they disguise it by saying it's not medically necessary. Well, how do you determine something's not medically necessary if you're an insurance company? Isn't that the doctor's job? So, of course, they've manipulated the system to where now they're able to say things are not medically necessary whenever they want to, for no reason whatsoever. Okay? And I'm sure denial for not medically necessary started out as a legitimate denial probably 50 years ago when they refused to pay for, say, a knee MRI that the doctor accidentally ordered instead of a brain MRI for a brain tumor in a patient. So if a patient has a brain tumor, you own a brain MRI, but accidentally your staff order a knee MRI instead, of course you should deny that. The patient doesn't need a knee MRI if they don't have a knee problem. But that's changed over the years. It's morphed. So it's now they deny everything. Well, you want blood test? Denied. You want a medication for your patient? Denied. You want an MRI? Denied. You want x-ray? Denied. You want CAT scan? Denied. You want surgery? Denied. You want an office visit? Denied. You got to go to your primary care doctor. They'll punish the primary care doctors for referring patients to the specialist. They'll punish them financially. They'll pay them less. They won't contract with them. They'll cut them out of the network. They do all kinds of dirty things that nobody really knows about. And so it's time we talk about it. It's time for me to bring it to you. Why? Is this spine surgery? Yes, it is. This is all health care. This discussion is about every single human being that gets health care, and this discussion is about every treatment and every doctor and every specialist and every nurse and every therapist. And you all better wake up, and you better smell the coffee real soon, or we're going to be a very, very, very sick nation, which, by the way, we already are, but you just don't know it yet. But if you start looking around, you're going to see a lot of people with illness and disease that's chronic, that's not getting fixed because the insurance companies aren't paying for it. We can't allow them to do that. All their risk models, all the money they take from you guys in premiums, co-pays and deductibles, it was all calculated and it should work. But the problem is they're siphoning it all off as profit now. There's nothing wrong with a business making a little bit of profit, but making 80% of every dollar they collect as profit is wrong. And people are going to challenge me on this and say, you're wrong, Dr. Dugmajan. They only make 20% profit. No, they make 80% of every premium dollar profit. Blue Cross Blue Shield does. I'm sure State Farm does. But the way they do it is they actually have companies that they create that are service companies that service the insurance company. Okay? So it's kind of like the mafia, right? The boss gets the suitcase full of money, and then he pays it out to all of his workers or her workers, right? They all get their cuts, right? So who's getting the cut in the insurance company are the service industry, service companies. So in the news today, United Healthcare is buying the service company for $3.2 billion, right? I forgot the name of it. But they keep expanding their reach and buying companies for billions of dollars because they're making billions of dollars. I'll give you an example. If I'm the insurance company and I want to make profit that the government can't regulate because they can regulate the profit that I make as an insurance company by law, that's what Obama signed in place. If I want to make more profit, I'm going to create a janitor company that's going to come in and clean my building. And instead of paying the janitor company $1,000 a month, I'm going to pay them $10 million a month. But I own the janitor company. Well, the janitor company is not regulated by the government. The profit of the janitor company is not regulated by the government. It's a janitor company. Who cares, right? Nobody's really looking at the janitor company. But the janitor company is what's siphoning off billions of dollars. And by the way, these janitor companies, subsidiary companies that are owned and controlled by the insurance companies, and they're very powerful elite, they're actually overseas registered. So they don't even pay taxes in the United States. So basically all this money we're paying in premiums to these insurance companies is being, diverted overseas to bank accounts for companies that aren't even paying taxes in the United States. So all this is happening and no one's talking about it because the insurance company have this poisonous cloud over the entire country and people are gasping for air and nobody's brain is working. But the fact of the matter is I've been watching this now and I've been trying to educate people about it for the last 20 years. I could see it happening on the horizon 20 years ago. An insurance company should never be able to deny care to a patient. And that is what you all have to fight for. You're going to have to go to the polls. You're going to have to elect officials who are going to make this happen. Because as long as insurance companies can deny your medical care, they're going to. And they're going to deny all the care that you actually need. And that's already happening today, and it's been happening for the last 10 years. And there are people dying of cancer that could have been treated. There are people that are dying of diseases because they're not getting the right treatment or medication. And this is not bigger than spine, but this includes spine. Okay? So I'll shut up now, and I'll take some questions if we have any. And if we don't, I'm going to have lunch. What do we got, Zach? Have I ever done surgery on a professional athlete? Yes. You want to know their name? Sorry, I can't tell you. That's a HIPAA violation. I would never violate a law. That's a federal law. So yes, I've done surgery on professional athletes. I'm not afraid to do surgery. I could do surgery on anybody you want. I'm not afraid of it. I'm not afraid of complications. A lot of doctors get scared. The only thing I would say is if you're a singer and you have a professional voice, you want to be very careful about having surgery done on the front of your neck, which is the ACDF. We just did a surgery today, the Duke laser disc repair, where it would be perfect for someone who's a professional singer because you don't get all that scar tissue after the surgery like you do with an artificial disc or an ACDF. But yes, I've operated on professional athletes. We can accommodate them, no problem. We even have VIP private recovery and pre-op, so they have privacy. All right, that was our last question. So I'm Dr. Ari Dugmajan. Thanks for joining us. We have 2 more Duke laser disc repairs coming up. The next one is a 4-level lumbar. I thought the patient needed 3 levels, but the patient was concerned about another herniation they had at another level, but I didn't think it was symptomatic, so I wasn't going to treat it, but they wanted me to test it anyway to see if it's painful. So that 4-level Duke laser disc repair may actually become a 3-level if we don't need to treat that 4th level. All right. Well, hopefully you'll join us for the next surgery. If not, until next time, have a great day. Don't forget to check out the Duke Spine Institute app. It's free to download. It's free to download and free to use. And honestly, if I had a spine problem, I would download it because it's an incredible app. It's got a lot of great resources and it allows you to connect to Duke Spine Institute. You can watch live surgery through it. You can, I think you subscribe, or you can somehow get notifications about the surgeries, right? And Zach basically built it, but with Sonny and my input and Zach's input. And if anybody has a recommendation on the app, they want to change something or add something, let us know. We're very open-minded to things. Ultimately, the app is for you guys, not for us. So anyway, check it out. And remember the Facebook group, Spine Surgery Support Group. If you're interested in being part of the dialogue and discussion, you can ask me questions any time of the day. I personally answer those questions at Spine Surgery Support Group. So have a great day. Talk to you later.